Hey everybody, welcome. I'm glad you're here. I knew this could work two ways. Either everybody would be here because of the rain or nobody would be here because they're coming late to the game. So I'm glad you're all here. My name's Angie Cavalieri. I'm at the Harper Cancer Research Institute. I also have the pleasure of directing the Clinical Alumni Network. So if you're on Irish Compass through the Alumni Association, please consider joining our industry group. I am also here representing today's Science Exploration Series, the College of Science. I see some of our people coming here today. Hello, Dr. Marino. Hi. So let's go ahead and get started here. Welcome to today's Science Exploration Series and the Notre Dame Clinical Alumni Network's Fall Lecture Series. We're so glad that you're here, and we're happy to give you some respite from the rain. We just have one more lecture remaining in our regular Saturday series during the November 18th Wake Forest game. Felipe Santiago Tirado will speak about fungal pathogens. Okay. It's called The Last of Us is the name of it. You'll understand that I am not a clinician, and some of this stuff really grosses me out. We hope you'll be here to join us as well on that day. So today I'm pleased to introduce Dr. Charlotte Marous. Dr. Marous received her Master's of Global Health degree from Notre Dame in 2012. Anybody else? Anyone else have kids by 2012? Okay, so she is an oculoplastic and ocular surgeon at Wills Eye Hospital in Philadelphia, Pennsylvania. There's always a risk of acute vision loss or blindness due to bleeding complications in surgery, and Dr. Marous recently concluded a large clinical trial comparing different protocols to limit the complications during facial plastic surgery around the eye. She'll share the result of the study, including the successful surgical modification, implementing, okay, here we go. Tranexamic acid, that's exactly how I was going to do it, to reduce bleeding, improve safety, and optimize patient recovery in the eyelid and orbital plastic surgery. Dr. Marous holds a degree in health and exercise science in chemistry. What? It is? Okay. From Wake Forest University. After graduation, she earned her Master's of Global Health from the University of Notre Dame and her medical degree from St. George's University School of Medicine. She has completed some ophthalmology residency at SUNY Downstate. I should have gone over this with her prior to this. SUNY Downstate Health Sciences University. She's also an ASOPers. That was my next guess. Oculoplastic Surgery Fellowship at Lions Eye Institute, Albany Medical College. In addition to her work at Wills, she holds a position as Assistant Clinical Professor in the Department of Ophthalmology at Thomas Jefferson University, Sidney Kimmel Medical College, where she earned the Golden Apple Faculty Teaching Award. Thank you, Dr. Marous, for speaking with us today and for correcting my English. And thank you for supporting science at Notre Dame.
Thank you so much. Thanks for having me, everyone. Thank you for coming in on this rainy day. It's a real honor to come back to Notre Dame, and thanks for taking the time to spend this next hour with me. So as she mentioned, I am a new attending in Philadelphia. I just finished my fellowship and training, so I'm really excited to talk to you about some of the work I've done and new things I'm doing in my practice in Philadelphia. So I have one financial disclosure. It doesn't correlate to anything that I'm going to talk about today. So what is oculoplastic surgery? A lot of people have never heard of it before. So it's a small, highly specialized field within ophthalmology focusing on the treatment of the upper face. And that includes the eyelids and eyebrows, the bones of the eye socket, which we refer to as the orbit, and the tear drainage system, which is referred to as the lacrimal system. We treat diseases of these structures, ranging from eyelid malposition to droopy eyelid, facial trauma, reconstruction of large facial lacerations. Okay, so we treat reconstruction of large lacerations, infections, tearing concerns, cancers involving any of these structures. So often it involves the paranasal sinuses and the skull base. So we're working alongside our colleagues in ENT, oral maxillofacial surgery, neurosurgery, and medical oncology. So this variety and complexity is really what drove me to this field. So my practice spans both functional and aesthetic realms. So I wanted to show you a few pictures just to show you the types of surgeries that I perform routinely and how this new medication can impact outcomes. So this patient here has what we call ptosis. It's a droopy upper eyelid. On the upper photo, you can see her lid margin is covering a large extent of her pupil and therefore reducing her vision, the superior visual field and her peripheral visual field. So surgery in these patients involves finding that muscle that elevates the eyelid, in her case the levator muscle, reattaching it, tightening it, and then suturing it up. So this would be considered a medical necessity or functional surgery covered by insurance. There are a couple causes of why people develop droopy eyelids. It can be due to just aging and laxity of that muscle. It dehisces and then you develop this ptosis. It can also be due to trauma. It can be due to patients with muscular dystrophy that have myogenic ptosis, and then paralytic patients that have strokes and cranial neuropathies can develop droopiness. They're all fixed in different ways. The majority of what I treat is involutional or age-related, which is what this patient had. The next one here is similar. This patient had ptosis as well due to age-related changes and loosening of that muscle. You can also see on his lower eyelids, they're a bit loose. You can see the white part of the eye underneath. That's called retraction. And the eyelid is so loose that the lashes are turning inward and rubbing against the cornea. That can lead to dryness, irritation, foreign body sensation. It can even predispose to infections, corneal thinning, and corneal perforation. So it's important to fix these. So for him, what we did is we tightened the lower eyelids and we put some stitches in to reposition the margin so that those lashes were no longer touching the cornea. And then we also raised his upper eyelids by tightening that muscle, the levator muscle. So this as well would be considered functional surgery or medical necessity. Next, we're moving on to more of an aesthetic type surgery. So this patient came in complaining of extra upper eyelid skin, and he has some bulging fat pads medially kind of near the nose there, and that happens with age as well, that you have fat that kind of protects the eye in the eye socket, and as you age, it can protrude forwards and create these bags. It can create lower eyelid bags and then puffiness in the upper eyelids. So he was bothered by this. What you notice is his upper eyelid position is actually not covering the pupil as much as those first two patients, so he doesn't necessarily have ptosis. He has what we call dermatochalasis. So for him, what we did is when we removed that upper eyelid skin and debulked the fat pads, sculpted it a bit, and really allowed those eyes to brighten up and remove that extra skin. So he was very happy with the result. And lastly, this is more of an aesthetic patient as well. So she was bothered by her extra skin that was drooping and hooding over the eyelashes. So she reported she wasn't able to wear makeup. She felt like this extra skin was hooding over her peripheral vision and her superior vision. So we were able to remove a little bit of skin there and open up her eyes. She was able to wear makeup again. So this would be more of a an aesthetic surgery. So when performing these eyelid surgeries, understanding the anatomy is very key. The periocular region is supplied by a very vast a network of arteries and veins, and you can see they expand, upon the upper eyelid, the lower eyelid, and then go back in towards the eye socket. So surgical manipulation of these tissues can result in pretty significant bleeding, preceptally, so along the eyelids, and then postseptally back in towards the orbit. After surgery, these patients often suffer from unsightly bruising or hematomas. The eyelid skin is some of the thinnest skin in the body, so any amount of bleeding is very visible. This leads to prolonged healing time, reduced patient self-confidence, and it negatively affects patient assessment of success. So all of these patients notably had surgery only of the upper eyelids, but you can see with gravity, the blood, bruising, and swelling, it does go down towards the lower lid and the cheek junction. These photos are all about within the first week after surgery. And so it goes away with time, but that prolonged healing time does have an impact on the patient's overall happiness and their recovery. Severe bleeding and swelling perioperatively can even lead to what we call an orbital compartment syndrome. So that's when the bleeding goes and extends behind the eyeball posteriorly. It can cause congestion of that socket, of the muscles, of the optic nerve, and the surrounding vascular structures, leading to vascular occlusions to the vessels that supply the retina and other important structures in the eye. So it can lead to permanent vision loss. And you can note here in that right eye socket, the eye is proptotic, so it's bulging forwards, and you can see it just looks a little blurry back there behind in the eye socket. That's all blood. So when this happens, patients really are at risk for permanent vision loss. And these complications are of higher risk in patients that are taking blood thinners.
So the majority of our population is on at least one anticoagulant for health optimization. So although these are critical for maintaining cardiac and vascular health, they can be detrimental in surgery and significantly increase the risk profile and difficulty of these simple eyelid procedures from a surgeon's standpoint. The risk is even more so a concern in the precious territory of the eyelids where vision can be impacted. Discontinuing these, unfortunately, prior to surgery in an effort to reduce these bleeding complications isn't an option in all patients, and it can theoretically lead to thrombotic events such as stroke. So here we have the coagulation cascade, which is every medical student's nightmare. But this is a very simplified version. So let's just start at the top here. Tissue damage causes bleeding that will then stimulate this whole clotting cascade. Blood thinners work by blocking the steps in this upper portion of the pathway to prevent this fibrin clot in red from forming. This is helpful in patients with atherosclerotic disease or hypercoagulable disorders where you don't want excess clotting. But as surgeons, we induce lots of tissue damage that causes bleeding, and our goal is hemostasis. In other words, we depend on this fibrin clot to form and to stabilize blood loss. This is why we like our patients to hold their blood thinners perioperatively, because without clot formation, the stabilization of the clots is jeopardized. So this takes us to the bottom part of the pathway. So clots are ultimately degraded by plasmin, and overactivation of this fibrinolysis pathway can lead to accelerated degradation of the fibrin clot and excess bleeding. By blocking the breakdown of clots, we can stabilize the body's natural hemostasis to reduce further bleeding without causing extra clots. This is where tranexamic acid comes into play. So it's a synthetic antifibrinolytic. It is a potent inhibitor of the enzymatic breakdown of fibrin by binding to lysine receptors on plasminogen. Therefore, it blocks formation of plasmin and impedes degradation of the fibrin clot, leading to stable clot formation. And by blocking this activation, platelets are preserved for later clot formation. Lastly, an added benefit, by inhibiting plasmin formation, there is some anti-inflammatory role. So plasmin promotes crosstalk with these inflammatory proteins called interleukin-6, creatinine kinase, and C-reactive protein. So it may reduce these inflammatory proteins and thus decrease local edema within that first postoperative week. So just an added benefit. To assess safety, I looked at a large randomized controlled trial that was performed in trauma patients. So this was looking at effects of tranexamic acid on death, vascular occlusive events, and blood transfusions in trauma patients with significant hemorrhage. And they found that using 2 grams of IV tranexamic acid in the setting of trauma did not lead to any increased risk of stroke, myocardial infarction, deep vein thrombosis, or pulmonary embolism, and more so is mortality protective. So, this gave me some confidence in using this medication. The risk of it inducing problems and more blood clots was not shown to be the case in this large trial. So right now, TXA is used very commonly in to reduce the need for blood transfusions in cardiac surgery, ortho joint reconstruction, hepatobiliary transplantation, obstetrics, and trauma surgery. The uses in ophthalmology are limited and show mixed results. So there are 2 main studies that are out there right now. This one by Gaberbe in 2019 looked at TXA in reducing the rates of rebleeding and decreased time to resolution in traumatic hyphemas. So a hyphema is when you have bleeding in the anterior chamber of the eye. That can lead to pain, discomfort, high eye pressure, and ultimately vision loss. They found that using oral TXA, their protocol was 1.75 milligrams per kilogram per day for 5 days, up to 1.5 grams per day for 7 days. Reduced this rate of rebleed, but the benefit didn't reach clinical significance. The second study was looking at, by Ramazani et al. In 2005, post-vitrectomy hemorrhage in diabetic patients. So diabetic patients have fragile vessels that tend to be very leaky, just to oversimplify it, that can lead to bleeding in the vitreous in the back part of the eye. So they were looking at using IV TXA, 1 dose in pre-op and then another one after surgery followed by an oral regimen. And they didn't find any changes in post-vitrectomy patients. So that's retina surgery in diabetic patients. So more recently, the use of TXA in facial surgery is gaining traction in Mohs micrographic surgery, in aesthetic plastic surgery, in treatment for bleeding, edema, and ecchymosis in patients undergoing rhinoplasty, It's also used in nasal surgery, endoscopic sinus surgery, and then in rhytidectomies, so facelifts. So in these aesthetic surgery studies, they found that using TXA reduced intraoperative bleeding, it improved the visibility in the surgical field, it decreased postoperative eyelid edema and ecchymosis in rhinoplasties, facelifts, and liposuction, so they usually develop edema in the surrounding structures where they've had the surgery. And one study also found that the anti-inflammatory benefits found when used in rhinoplasty were similar to dexamethasone. So often when we're doing facial surgery, we will give the patient a dose of steroids that will reduce the postoperative swelling. There are reasons, steroids are not safe in all patients. They can cause elevated blood glucose in diabetics. They can cause mood swings, difficulty sleeping. Not all patients tolerate them well. So this is really exciting to know that potentially TXA could replace the need for using that in these types of surgeries. So the dosing really remains quite controversial. You can see in some of the studies I presented, the teams were using oral regimens, IV regimens, or topical regimens where they would inject it directly into the tissue. There's not one protocol that's been elicited as the optimal one, and very few studies have looked at them head to head. One study, it is agreed upon that 10 milligrams per kilogram is required for 80% inhibition, and it remains therapeutic for almost 24 hours. Higher doses than this have not found to be of increased benefit. So using that is kind of what I based my study off of. So like I mentioned, few have compared the outcomes of oral, IV, or local TXA in surgical patients, and of those, there have been one or two. They were all in orthopedics, which is a lot more blood loss than I'm going to have in my surgeries. So my clinical question was, does preoperative TXA administered intravenously or subcutaneously mixed with the local anesthesia reduce postoperative ecchymosis, which is bruising, and edema, which is swelling, in patients undergoing periocular surgery? And I was interested to determine if this could improve surgical outcomes, reduce potential risk of vision-threatening bleeding in these types of surgeries. So my primary outcomes were looking at ecchymosis, which again is bruising, and edema, which is swelling. I was also looking at if it affected operative time, intraoperative pain in the patients, hematoma formation, time until resuming activities of daily living, patient satisfaction, adverse events. So the way that I did this was I performed a single-center, double-blinded, prospective, randomized, placebo-controlled study. I looked at all patients over 18 years old who were having upper eyelid blepharoplasty surgery, and I chose this surgery because it's one of our most frequent ones, so I was able to recruit more patients easily and increase the power of my study. And I wanted to start small before I went to the larger surgeries. Exclusion criteria included history of previous eyelid surgery, history of bleeding disorder, history of thromboembolic events or seizures. If any patient was on oral contraceptives or hormone replacement surgery, this makes them more prone to clots, so I wanted to eliminate them from this. If they had planned combined surgery on any eyelid on the same day, and those who did not comply with postoperative follow-up schedule. Patient preference was also a reason to exclude. So I didn't exclude patients that took anticoagulation, daily NSAIDs, fish oil, or vitamin E. Rather, I just noted what drug they were taking and whether or not they discontinued it. So this is a little bit of a busy slide, but I'll go through it. So treatment group 1 received IV TXA as a bolus prior to surgery. Treatment group 2 received local TXA mixed with their anesthetic that we injected in 2 minutes prior to surgery. And group 3 was my placebo or control group. They did not receive any of the TXA. So patients were randomized into one of these groups via a random number generator. And the group assignment was only known by the anesthesiologist and the nurse who administered the medications. And so the surgeon was blinded to it. We don't like to use blinded in ophthalmology, but they weren't aware of it. And the patient wasn't aware of it. So that's kind of how we controlled things. So just to make it easy, if you look, each group received an IV bolus of 100 mLs of normal saline, which you can see right here. The only difference was the first group, that bolus had IV TXA in it. So they were standardized in that way. All groups also received local anesthesia. So we mixed 2% lidocaine with epinephrine, 1 to 100,000, which is kind of our standard of care. And we mixed it with saline in a 1-to-1 ratio. We did that for groups 1 and 3, and group 2 received, it was mixed with the TXA. So we kept the concentration of the anesthetic stable. All patients received 1% lidocaine with 1 to 100,000 epinephrine. And there was also a study that I looked at that showed that mixing of TXA with lidocaine did not interfere with its properties of being an antifibrinolytic. So all operations were performed by the same 2 surgeons using the same technique and instruments at 1 surgery center. All surgeries were performed under intravenous sedation. And then just to reiterate this, all patients received that normal saline bolus 20 minutes prior to surgery, and all patients had local anesthesia 2 minutes prior to incision. They weren't aware what concoction they received. So immediately following surgery, we asked the surgeon to record the efficacy of hemostasis on a 4-point scale, and I took this, adapted it from another paper. So a score of 1 was excellent, better than expected for this type of procedure. Type 2 was good or as expected with this type of procedure with minimal oozing. Type 3 was moderate, less than optimal, and type 4 was poor. The surgeon noted oozing without the presence of a pumping arterial bleed that required extra local pressure and cautery. So then the patient was also asked if their level of intraoperative pain, and I used a Likert type scale from 0 to 10, 0 being no pain at all, 10 being the worst pain of their life. We then took photographs on postoperative day 1 and postoperative day 7 to assess the bruising and swelling. And the patient was asked to assess it, and we had 2 trained ophthalmology resident graders that also assessed it as well. The patients were examined at these time points and questionnaires were collected. So we asked all of them how many times the patient used ice cold compresses, how many days after surgery they returned to activities of daily living. And the way I asked this was, are you able to go grocery shopping, drive your car, read the newspaper? I asked if they used Tylenol, NSAIDs, or resumed any anticoagulation. And then we asked them if they had any seizures, focal weaknesses, extremity pain, difficulty breathing, or any emergency room visits to assess for adverse effects. And this is the grading score that I used. So I also adapted it from another one of those papers that I showed you before. So on the left side, right here is what I used to assess bruising or ecchymosis. So the patient got 1 point for each half of the eyelid that showed bruising, and they got 1 point if the cheek was involved. So if it was just the medial aspect of the upper lid, they had 1 point. If it was the full upper eyelid, they got 2 points, and so forth. For edema, I used this scale here. So 0 was no edema. 1 was if there was a minimal amount of edema with no coverage of the iris, which is the colored part of the eye. 2 was if they had iris covering edema. 3 is if they had pupil, so the dark part was covered by the swelling, and then 4 is if they had full closure of the eyelids. The degree of this, of the bruising and swelling, was collected from the patient as well as from those ophthalmology graders, and those 2 physician residents independently graded. They weren't aware of what these patients had, what treatment they had. All they knew is that all these patients had an upper eyelid blepharoplasty. And then the averages of these scores were taken and analyzed, and we also analyzed inter-observer variability statistically. So statistical analysis: at the completion of the study, scores were aggregated to calculate means, medians, and ranges for each of the groups, and the results were analyzed using GraphPad Prism. An analysis of variance was used to determine the significance of these findings, and we used a non-parametric one-way ANOVA test to compare variables between groups, and then a non-parametric unpaired two-tailed t-test to look at subgroup analysis. And a p-value of less than 0.05 was considered statistically significant for this study. So I looked at 106 consecutive patients and assessed them for eligibility. 6 were excluded, so 1 had polycythemia vera, 1 had a history of PE, and 1 had a history of DVT. 3 chose not to participate. Of those, we had 100 patients, and they were randomized to one of those 3 treatment groups. We had a few that were lost to follow-up in each, but we ended with 30 patients in each group. So here are the results, my demographic features. So in terms of patient demographics, there was no significant difference between the 3 groups in age, smoking status, presence of hypertension or diabetes, or previous use of anticoagulation. When comparing the gender distribution of the groups, that revealed more males in the control group. but I didn't find that to be too impactful in terms of my results. So my primary outcomes are listed here. By comparison, looking at IV TXA versus local subcutaneous TXA versus no TXA, both ecchymosis and edema scores were significantly lower on both postoperative day 1 and day 7, and you can see the p-values listed there. And here's just a graph showing that as well. So in the dark blue are the IV groups on day 1 and day 7. In gray is the subcutaneous group on day 1 and day 7, and then the light blue is the control group. So like I said, on comparison, there was a significant difference between all groups at these 2 time points, but when I did subgroup analysis, I found that there was really only a significant difference between the IV group and the control group. When I compared the local group versus the control group, even though the score was lower, it didn't reach the level of significance. And when I looked at the 2 treatment groups, the IV versus the subcutaneous, these 2 numbers also did not reach significance. So truly, on subgroup analysis, the only thing that was significant was the IV TXA and the control group, and that was the same for postoperative day 7 data as well. This is looking at the edema score, so similar but a little bit different. Both the IV and subcutaneous groups were independently significantly lower than the control group on day 1. By day 2, only the subcutaneous was significantly lower than the control group. And there was not a significant difference between the 2 treatment groups on subgroup analysis. But you can see overall the trend is towards lower numbers in both treatment groups. So here are some composite photographs of the study participants on day 1 and day 7. So I would ask patients to look straight ahead and took a photo that way, and then I would ask them to close the eyes so that we could really see the extent of the bruising. The eyes open allows us to see the extent of the swelling. So here you can see this is a patient who received IV TXA. This is her on postoperative day 1. You can see she has a little bit of upper eyelid swelling and bruising, but by day 7 she's looking really good. The local subcutaneous group, similarly, the bruising and swelling on day 1, it's kind of descended now into her cheek junction as a result of gravity, a little worse compared to the IV, but still nothing like the control group. So you can see this patient has pretty significant swelling and bruising that even by day 7 was still fairly apparent. And these are representative photos. Of course, there are some on different sides of the spectrum, but to validate the scores between edema and ecchymosis, we did, like I said, perform inter-observer variability testing between the 2 physician graders, and there was no significant difference in the scoring patterns of them, so we felt that their scoring was reliable. So in terms of secondary outcomes, we have a chart here listing those. So we did find a significant decrease operative time in the treatment groups. Better hemostasis, so lower scores for that. We also found that the patients who received the TXA were able to return to their activities of daily living sooner rather than ones who didn't. And then patient satisfaction on day 1 was significantly higher in the treatment groups compared to the untreated groups. On subgroup analysis, the only thing that was significant between the IV and local was this efficacy of hemostasis here, right here. So the operative times, this 10.8 and 11.8 was not significantly different between the 2. Same here, days until resuming ADLs was not significantly different between the 2 treatment groups, but it was when comparing it to the control group. And then patient satisfaction as well was significantly higher between the 2 treatment groups, but on subgroup analysis, those 2 numbers were not significantly different. So in conclusion, I've shown you that bruising and swelling following eyelid surgery can produce negative impressions and impacts on patient experience. It can prolong the recovery time, decrease patient satisfaction and perceived success of surgery. In severe cases, it can even lead to that permanent vision loss. So TXA is gaining popularity as a safe antifibrinolytic agent across multiple surgical subspecialties. It's used as standard of care in orthopedics and OBGYN, as well as craniofacial surgery, but it's newer to the facial aesthetic surgery realm. It's been shown to reduce blood loss, improve surgical fields and surgical precision, and reduce postoperative bruising and swelling. But dosing, timing, and route of administration for optimal clinical benefits still remains controversial. So what I found in my study is that using this medication, both IV and local, was associated with improved early postoperative patient experience. It was associated with significantly reduced bruising and swelling during postoperative week 1, and patients were faster to return to their activities of daily living. It also showed a reassuring safety profile as no patients had any adverse effects. Clinical superiority with IV dosing was suggested when compared with the subcutaneous formulations, but in my study I did not reach clinical significance on that subgroup analysis. I also found that mixing of TXA with the local anesthetic did not impact the anesthetic effect or induce any harm to patients. None of them said that they felt the surgery more, having it dilute lidocaine, and no patient had any adverse effects like I mentioned before. A few limitations to my study is that the sample size was a little small. It was 100, although it's the largest one in facial plastic surgery. And the timing of dosing was not completely uniform. So as you may recall, the IV doses were given 20 minutes prior to incision. The local doses were given just 2 minutes prior. And I designed this on purpose to mimic real-world behavior. So surgeons usually inject their local anesthetic right before they make the incision, or 2 minutes before. That's how I do it. You know, you roll the patient into the operating room, they get some sedation, and then you numb them up and you start the surgery. It would not be realistic to numb the patient 20 minutes prior to surgery and sit there for 20 minutes. OR time is precious. And so designing a study in which that was the protocol, I didn't feel like would be very generalizable. And I think that also shows why IV doses may be the way to go, because the nurses can administer them in the preoperative bay before surgery. It does not increase the surgical time at all. It doesn't delay you as a surgeon. And so that also allows ample circulation time for that medication. And so it's just a little bit more efficient. Future directions, I hope to expand this to other aspects of my surgical practice. So as you saw before, I do surgery on the eyelids, the orbit, and the lacrimal system. The lacrimal and orbital surgery tends to be a bit bloodier. We're dealing with larger blood vessels deeper in the eye socket. And so I think this could may be able to reach, have a more significant impact in those types of surgeries that tend to induce more significant blood loss. But for now, I wanted to start small and go from there. And those are my references. Thank you so much to all of you for coming. This is my family, and this is me at Will's Eye with my aunt, who is also an ophthalmologist there, and my uncle's in the audience, who's also an ophthalmologist. So I have lots of good people to learn from. If you have any questions, I'm happy to take them.
One of the things that I have seen over years is, even with the crash 2, after the crash 2, it looked like every trauma patient everywhere should be getting TXA. And then subsequently, it just didn't carry out. That people are not doing it consistently. Mm-hmm. Some people have done other studies that just don't show the same things. And, your study isn't dramatically different from the 2 others that you pointed out. Mm-hmm. What do you think is the difference that made yours? What was different that made you have statistical significance? And then the second part, another question that I had is most surgeries like this, people are using bone-racking anesthetics, I think.
No, you mean like Marcaine or?
Like bupivacaine.
Yeah.
So have you considered whether or not there's any interaction with DXA or other bone-racking?
So I'll answer the second question first. I don't typically use bupivacaine in these surgeries because they're pretty fast surgeries and the patients tolerate them well. A blepharoplasty can take 25-30 minutes. When I'm doing orbital surgery, I do use bupivacaine because it induces more pain and it lasts longer. So I don't use bupivacaine typically, so that's why I didn't include it in my study, but it could be something that we look at definitely. And in terms of the significance, are you referring to the other ophthalmology studies or the other ones in facial plastic surgery? Which ones? Well, I would say that maybe the trend in these other studies that maybe didn't reach significance but was suggestive, they had pretty low sample sizes. Mine is still pretty low too, 100 patients. I hope to increase that, and I think once we increase that, we may be able to reach a level of significance. I think we've all kind of suggested the same things, and mine got a little closer than the other smaller studies, but we're not there yet. I think overall the results are encouraging. The safety profile is encouraging. It's a cheap medication. It costs $10, and the hospitals have it on formulary because I think it depends on the institution, but where I am, they use it routinely in all of their general surgery and orthopedic cases, so it's easy to administer, and the anesthesiologists are comfortable giving it. So right now I use it IV in all my patients, and I'm even starting to use it soaked on neuropatties, and I can lie it in the wound for hemostasis, and I do it kind of two ways. And I found that patients' recovery has been pretty good so far.
It's kind of interesting because it seems like the obvious thing is inexpensive, it doesn't have much in the side effects, it looks like it's shown not to have complications, and yet it just hasn't been accepted universally.
Yeah.
I don't think I really understand why.
I don't think there's a good answer. You know, some facial plastic surgeons I talk to say, oh yeah, I've been using it for years. It's standard in my practice. Others maybe just aren't as aware of it. I don't think they don't use it because it's difficult to get, or they have apprehensions about it. I think maybe it's just, at least in our community, so in our oculoplastic society, there's been one talk on it ever, and in the last 2 years, I'm giving a similar talk in a month. It'll be the third time it's been brought up in our society. So I think it's just not well known yet in the smaller subspecialties. You know, we don't have the level of blood loss that the trauma patients have, so we're not overly concerned with blood loss in that respect. I'm using it more for patient experience and improved aesthetic outcomes. And so maybe that just hasn't really been on the forefront of the surgeon's mind because it's not life or death necessarily for me, but around the eye it does risk vision loss. So.
It might be difficult also because of the effectiveness of this drug in people. Okay, so if you're repairing a leg fracture or thoracic injury with blood in the brain and aiming for it, it might be harder to notice to do this type of visual observation.
That's true, yeah. Right, yeah. Yeah.
You mentioned that anesthesia was not blind, or I guess was aware of its use. Was there some specific systemic? Wait. All right. From the anesthesia standpoint, were there any systemic interactions that they need to be aware of, or was there some other reason why they were not blind?
Why anesthesia? The anesthesiologist was not blinded because they were giving they sometimes gave it as the bolus in the pre-op because they would sometimes place the lines. And so they were hanging the medication. That's why they were not blinded to it. And then the nurse in the room who was handing the surgeon the coated syringes was not blinded to it.
But no systemic interactions?
No, we didn't note any. Yeah.
You spoke about the circumstances, the unusual circumstance when there was an accumulation of blood behind the eyes. Were you able to identify that and either arrest it or reverse it so that you could avoid the permanent vision loss?
Yeah. So we're trained a lot on that in residency. The way that you tell is the eye will become firm, it will bulge outward, the lids may not be able to open, the patient will complain of significant pain. It's pretty easy to tell. It happens very quickly, and the eye pressure will become high. So the way you treat it is you perform a lateral canthotomy, which is a cut along the eyelid here on the corner, and a cantholysis, and that just allows the lid to expand out more, so it's not like a belt buckle on the eye, and it allows the blood to escape as well. Sometimes if we get patients who have been in car accidents and have been down for 2 hours and they come in with a rock hard eye pressure of 50, at that point we may do a lateral canthotomy and cantholysis, but it's been too long, they've lost vision. Sometimes the blood's also clotted there, so even if you release that lateral canthus, the blood products don't come out. Sometimes we need to do surgery to remove them. But if they've come in and they have had that pressure for over 2 hours, their visual recovery is very limited. So it's pain management at that time. It's reversible if you catch it in the operating room because it'll happen quickly and you'll know. And so you can cut and release the blood at that point, and those patients do fine.
Thank you.
Mm-hmm.
Anybody else?
Oh, but I will say, just to tag along that, lower lid blepharoplasty can lead to slow bleedings behind the eyelid afterwards. It's more prone to postoperative bleeding, a couple days afterwards. So we tell all of our patients if they have pain or bulging of the eyes to come in sooner, and then we'd have to do that canthotomy. So the concern here in surgery is they can develop slower post-op bleeds. That's probably what your question was, that you wouldn't see right there on the table, but you'll know, and you can reverse it if they come in right away. That's why you give them strict return precautions.
All right. Well, thank you, Dr. Marous. And on behalf of the College of Science, we thank you for your time.
Thank you.
And thank you, everybody, for coming in and sharing your day with us. We give her a round of applause. And just remember, our next lecture will be prior to the Wake Forest game, so I'm presuming it'll be here or next door. I'm guessing 11:30, but please watch the game day for official notice. All right. Thank you.